Good afternoon, everyone. My name is Angela Keene. I am the Community Outreach and Volunteer Coordinator for Domestic Violence Services of Lancaster County. I also want to let you know that I have Monica Rodriguez here with me today. She's an intern working with me for the summer and fall. Allison reached out to me and wanted some information about who we are at Domestic Violence Services and what we do, and hopefully some ways, make some suggestions about ways that we can partner together, give you a better understanding of what we do and how we operate here. So let's go ahead and get started. We're going to record this so that way Allison can share it with the rest of the team who's not able to be here today. We are one of the many programs of the Community Action Partnership of Lancaster. We are part of the Safety and Empowerment Impact Team. So the way CAP is structured is that there's different teams and many programs which you may already be familiar with. Head Start, there's some senior centers, there's the Early Learning Resource Center. So we have been and are one of the programs of CAP since 1976. So for 44 years, we've been serving Lancaster County and have had this partnership with the Community Action Partnership. We are also the designated program in Lancaster County providing domestic violence services. So what that means is that we are one of the partner agencies with the Pennsylvania Coalition Against Domestic Violence. And there is a domestic violence program in every county in Pennsylvania that's providing the hotline services I'm going to tell you about. They should be providing safe housing, safe shelter. They might be providing counseling and support groups. But there's a domestic violence program in every county, and that's important to know because we may be working with folks who are transient, who are moving from county to county. We may know people, we may have our own, friends and family who are living in other places who might be in need of similar services. And so I just let everybody know that there are services that are free and confidential like ours in every county in Pennsylvania. And so you can find those services by going to the PCADV website. You can also call the national hotline. You could call us and we can help connect you to another sister program. Our mission at DVS is that we're a catalyst to end domestic violence in Lancaster County through direct service, advocacy, and social change. And that's not just what we hope to do. We really do want to aspire to that, and are in the process of doing more work around being more proactively visible in the community and really leaning into that part of ending domestic violence in Lancaster County. And so if you're interested in knowing more about that, please do feel free to contact me. We'd love to have that conversation with you. I myself have been doing this work for 22 years. I started out as a volunteer at the Sexual Assault Prevention and Counseling Center here in Lancaster, and have been doing the domestic violence and sexual assault work here in Lancaster and at the statewide level for the last 22 years. And so this is something that really speaks to me and something that I'm committed to and would love to see domestic violence end in our community. And there's lots of ideas about how we can do that. I'd like to do a quick, if I could find out who's on the call, because I'm really interested in a little bit more about what you all do and your roles there. So if you could, really quickly, I'll call out names according to the list that I have here. If you could just tell me your name, your role, a quick favorite ice cream flavor as a little icebreaker, and if there's any specific questions that you are hoping to have answered today, I would really appreciate that. So I'm just going to go down the list that I have in front of me, and Carlos, you're up first. So go ahead and unmute yourself.
Hello, everyone. Good afternoon. This is Carlos from Comprehensive Care. I'm a social worker here that recently started with LGH, working with HIV prevention, population, PrEP, PEP, And that's pretty much what I do here. Among other amazing things, we're working on SCI, on developing a new SCI clinic in October. So I'm looking forward to learning more about this and how I can continue helping the population and assisting, especially domestic violence.
Do you have a favorite ice cream flavor, Carlos?
I'm just boring. I like vanilla.
Next on my list is CM450.
I'm Cindy Mast, nurse case manager from Care Connections at Lancaster General. I am also here with another person.
Lydia Wolf, nurse case manager at Care Connection.
We're sharing the computer, watching together. I don't really have a favorite ice cream flavor other than maybe peach.
Peach.
What's yours?
Chocolate.
Okay, so as the nurse care manager, can you tell me what does that mean?
Well, we would be involved in placement if the patient was here in the hospital and needed placement, setting up home health. In our nurse role, we also take care of them in the office. They have any office nursing needs.
Okay.
Yeah, I
Some of the titles I'm just not sure of, so I'll ask the follow-up question. Thank you. Next on my list is DS195, an iPhone.
Can you hear me? This is Dan Sosa.
Yes.
Hi. So I am a patient care navigator in the Care Connections office. I work with Cindy Mast and Lydia Wolf, the previous speakers. So I'm a patient care navigator, and what that means is I go out to people's houses and I visit them and go over the medications. We review resources, upcoming appointments, do applications if needed for different things. And so I have my own patient panel that I kind of keep track of as they're part of our program.
Great, thank you. Do you have a favorite ice cream flavor?
Favorite ice cream flavor it's chocolate. I'm pretty boring too, but anything chocolate adjacent I like. I don't like fruits.
Yep,
Or anything
I'm
like
with
that.
you.
But
chocolate is solid.
Right.
Great, thank you. Next on my list is JL.
JL, you gotta unmute yourself, JL.
It looks like she is unmuted. We can come back to that. How about Kayla?
Hi, can you hear me?
Yes.
Hi, my name is Kayla Kinley. I work as a nurse supervisor over at Comprehensive Care, and I'm here with Suzanne. My favorite ice cream flavor would be Bunny Tracks. What about you, Suzanne?
Rocky Road.
Rocky Road.
Great, thank you. And it looks like JL sent us a chat that her computer microphone isn't working. That's okay. Well, if you don't mind, we'll just keep moving through the introductions. And if you want to answer those questions in the chat, that would be great. So we'll move on to Natalie.
Hi, my name is Natalia. I'm a clinical pharmacist at Care Connections. So my primary role is certainly overseeing the medication management of a lot of our patients, but I do have the opportunity to have face-to-face visits at Care Connections and Downtown Family Medicine, and have encountered, situations in which domestic violence maybe was a concern, and I'm just here trying to listen in and see what I can do if that happens. Again.
Okay, great. Thank you. And I'm sorry that I messed up your name, Natalia. Thank you.
No problem. And I like birthday cake ice cream.
Yeah. How about, I have some phone numbers, 544-5511. Not sure who that is. Let's go on to Allison.
Hi, it's Allison McCombie. I'm the program supervisor here at Care Connections, which is the high-cost, high-needs clinic at Lancaster General Health. So my role is to oversee the program side of our practice, and I work to support my team with patient issues that arise, such as domestic violence.
Great, thank you, Allison. Wekellum, W-E-K-E-L-L-U-M. Do you want to introduce yourself?
Oh, sorry, we had to hit star 6 on mute. This is Wendell Kellum. I'm a family doctor with Care Connections.
Okay, thank you so much. If there's
I'm on the same phone with him. It's Sabrina Millhouse. I'm one of the family docs at Care Connections as well.
Oh, great, thank you. I'm glad that you're both here. So if there's anybody who didn't get a chance to introduce yourself, please go ahead and do that in the chat. And feel free to put questions in the chat as you have them. You know, we'll try and make this as interactive as possible as we can with Zoom. And I can answer questions in real time or at the end as you may have them. So here's what we do at Domestic Violence Services. And I think that I want to spend a little bit of time talking about it because I think this is really a big piece of what you want to know and understand that. So we have a 24-hour hotline. This is a crisis hotline where we have trained staff, interns, volunteers. All of us are doing this work together to answer the hotline, to take calls as they come in. This is basically the point of entry for any of our services or getting information about our services and what we do here. People are calling in crisis sometimes. Sometimes people are, trying to get more information about what their options might be. We also work with local police departments to talk for the lethality assessment protocol, and I'm going to talk to you a little bit more about that later. But we can do safety planning and things like that through the hotline. We do also have a text line. This was added in April. So anybody who maybe can't make a phone call, maybe they don't have minutes, but they are able to text, they can text the word SAFE, S-A-F-E, to 61222, and they can initiate a text conversation with one of our staff people who are also answering that, as well as the hotline. So we have both of those modes of communication available. We also have a safe house, which some people often refer to as emergency residential services or a shelter. We call it a safe house because really it's a house. We are, 2 row houses that are connected. We have 13 bedrooms. When families come in, they have their own bedroom, single beds, bunk beds, depending on the size of the room. Here, during that stay here, which is usually up to about 60 days, every situation is different. We can make accommodations based on individual situations, but those safe house services, when they're here, they're engaged in safety planning, they're engaged in a case management plan to be able to identify goals that they want to work on, and we're here to help support them in moving through those goals. We also provide individual counseling here and support groups during their stay in the safe house. 4 nights a week, and this is under typical situations. We're still figuring some of these things out through COVID, but in typical situations, we have support groups that are running 4 nights a week here at the safe house for those who live here. And we have a self-care group, we have a DV education group, we do a house meeting for the people who live in the house. During that time, we also have children's programming that happens. And so we have a curriculum set up to provide group services to children by age group. And it's a trauma-informed, evidence-based curriculum that we use with the children. And we talk about big feelings with them. We talk about boundaries and how to learn what boundaries are and establish boundaries. we talk with them about what they've experienced, and how that might impact how they feel about different people. We talk to them and learn about self-regulation techniques, because kids get triggered all of the time, not just at home, but when they're in other public situations at school. And so we really want children to understand what's happening to them and how they can master taking care of themselves. So that's part of the children's programming that we run those 4 nights a week when parents are in group. Also a note, our services are not just women and children. We will provide services to anyone along the gender spectrum, and we also do house men here at the Safe House. If there's a reason why we can't bring somebody into the Safe House, we will find alternative services for them in a hotel or something like that. Right now, because we are not able to be at full capacity within the Safe House, we have about half of our residential clients living in local hotels, and we're providing the same services that we would here. And then the other half of our clients are here at the Safe House. So, we have figured out we haven't shut down during any of the COVID time. It's just a matter of adjusting and figuring out how our services will continue to operate. So that's one of the changes that we've had to make. The empowerment counseling and support groups is individual and support group counseling. We use an empowerment focused model, so we don't have licensed clinical people who are providing therapeutic services, but the services that we do provide are trauma informed and empowerment focused. And so that's really where our expertise is to be able to work with clients, meet their goals. They establish their counseling goals, and we work with them and support them in meeting those goals. We also have, once people leave our Safe House services, sometimes they transition into the community, into their own private housing, and sometimes they transition into one of our Bridge House apartments. We have 10 transitional housing apartments in another location, and these are apartments. It's an apartment building. We have another person running that program and providing case management services there. And those are for folks who are in a longer term operation. So they're there for up to a year, and they are doing things like maybe getting some more education, getting more acclimated and integrated into the community, and preparing to transition into the community after a longer term stay there. We also have our domestic violence legal clinic, and the legal clinic operates more under traditional business hours. We can work with folks to put together a protection from abuse order and walk through that process, the civil justice process. We work with clients who are seeking divorce, custody actions, any kind of civil legal issue. So there might be a disability claim that they're trying to work through, a landlord-tenant issue. But all of our services there are free to survivors of domestic violence, and it's a civil legal services. So we're not dealing with any kind of criminal justice matters there. And then out in the community, we're doing community education with adults and professionals, something like this. We also do school-based educational programs. Some of them are prevention education programs, and so we have several schools who partner with us, and we're regularly a part of their curriculum. Any kind of youth group, we're doing a series right now with the youth who are at the Youth Intervention Center. So we can pretty much put together, if we don't already have it, we can put together a training or group education for any kind of group who's looking for that. And then we also have our volunteer and internship program. Like I said at the beginning, all of us are trained, specially trained according to the Pennsylvania Coalition Against Domestic Violence standards. We go through 45 hours of initial training and then annual training of 10 hours a year. And this is, what we do. This is the services that we provide. So if there's any questions about that, please don't hesitate to ask. You can put that in the chat. You can unmute yourself and ask. But I'm happy to answer any more questions that you might have about our services. What resources do you recommend for individuals for housing when the safe house is full? That's a big one. So we do have a capacity of 13 residential clients. That's the number of bedrooms that we have. That's the capacity that we can basically serve. So we do often run full. And so what we do is when we're talking with folks, we try and help them find maybe a temporary situation, maybe a friend or family member who they can stay with, you know, at least in the short term until maybe we can do meet with them and maybe do a more complete assessment and then help them figure out what their next step might be. Sometimes we can refer them to other programs if they if it's safe for them or safer for them to go out of county. Sometimes people prefer to do that, so we can often make that referral. Depending on the situation, we might be able to put them in a hotel for, you know, a day or two until we, again, have another chance to be able to get to know them a little better and figure out what their resources are and what their needs are and help them to identify that. So it really depends on the individual situation. We do prioritize safety as the #1 reason for people who are seeking our services, for our safe house services. And so that means that there's an imminent danger that they're fleeing a situation. It's not to minimize the other types of abuse that they are experiencing or have experienced, because we know that sometimes the mental and the verbal abuse has even more impact than physical abuse. It's just that when we are prioritizing our residential services, we have to prioritize the imminent danger aspect of what they're experiencing, because that's because of the limit on our resources there. So today I just want to make sure that everyone's aware of the services that we have available and how to make a referral. We'll talk a little bit about the tactics that abusers use and the decisions that adults are faced when they're in abusive relationships, and then some quick safety suggestions, things that you might be able to use with the folks you're working with. So we talked about the services, and I also want to talk about making a referral. So you can give the client our hotline number or our text line number and encourage them to make that phone call or reach out to us. We will want to speak with them. We are also happy to speak with you. So if you call the hotline and say, you know, I'm working with this client and I'm trying to figure out what some of the resources might be, we can help you brainstorm in that way. But if it's anything specific about a client, we would want to hear from them first before providing any additional services. That's part of our empowerment focus model. And so we need to make sure that the person who is seeking services is really the person seeking services and that that's what they're looking for. It's not to say that we don't brainstorm often with other professionals in the community who are trying to figure out a situation and trying to figure out what resources might be available. We do that all the time. So please don't hesitate to reach out and ask some questions, but please also don't hesitate to give the client our direct hotline number. I also include information about self-care, and this is really because I believe that we're all doing incredibly difficult work. And it's important for us to take care of ourselves, because if we can't take care of ourselves, then we shouldn't, you know, it's hard for us to take care of others. There's an ethical obligation there, right? For us to be able to take care of ourselves as we continue to care for others. And so I really want to put that out there and say thank you for the work that you do, for the people who you serve, for continuing to commit yourselves to helping populations who are often overlooked and invisible in our community, and for taking the time to be here today. So Carlos is asking a really good question about the services. Are there any COVID-related requirements prior to providing somebody with referral or entry into our program? Not specifically. So we're not, if somebody is seeking our services, then we're going to provide them with services. If if there's reason to believe that they've been exposed to someone, or, maybe they're awaiting test results, we're going to hotel them during that time. So that way they have the opportunity to isolate there. There's also, in Lancaster, there is a housing program set up for people who either have tested positive for COVID or are awaiting test results. And I think that's through the Homelessness Coalition. But if we have somebody who brings that to our attention, we'll help them to self-isolate in a hotel space until it's an all clear. And then if we have space in the communal living residence, we'll bring them here or keep them in a hotel. Like I said, right now we're splitting our residential services between the on-site in-house services here at the Safe House, and then the other half are being hoteled. They're all getting the case management services, the support of all of our staff. It's just a matter of where we can house them because of the limits of COVID. So that's really where we are. That's how COVID has impacted our residential services the most. So helping people, to identify what we're talking about. Most of us could probably look at the spectrum and come up with examples of healthy relationships. Either we're in them or we've seen them in our life. We know that there's balance, that there's respect, that there are people who are, working together in their relationships. And we could probably identify some of those abusive relationships where there's a power imbalance. You can identify someone who's in control of the situation sometimes, maybe being victimized by the other partner in the relationship, although sometimes that can be tricky too, especially when there's not physical violence. When we're talking about mental, emotional, verbal abuse, gaslighting, those sorts of things, sometimes it's hard to pick up on that. We do see that control and isolation, jealousy, threats of violence and actual violence, those are all characteristics of abusive relationships, regardless of the type of abuse that someone is experiencing. So we're in the middle, is that unhealthy part of the spectrum. Oftentimes, abusive relationships may start out there. There may be that struggle for control in the relationship. There may be a pattern of dishonesty that's starting. So sometimes it's not even, it doesn't even start out as abusive, but it starts out in that questionable middle category. Sometimes things are good, sometimes things are bad. Sometimes there are aspects of a healthy relationship that present itself, but it hasn't yet moved into control or isolation. So it's important to recognize that this abuse doesn't typically happen just, right from the get-go. Most people would walk away in those situations, but it kind of sneaks up on you. And those are the things, and pretty much characteristic of every story I've heard from victims who I've worked with. And I'm going to send you a link to 2 of the stories that we have to share. The abuse just didn't happen immediately. It took time to get there, and that's part of the challenge of what makes it even more difficult sometimes to get out of. But we're going to talk a little bit more about that. So sometimes people are forced to make decisions that are very difficult for them to make. And I have an activity that I wanted to talk you through. So if you have pen and paper nearby, I'm going to ask you, I have 13 questions that I'm going to ask you to answer. And this will get us to some of those difficult decisions that adult victims are forced to make. If you don't have pen and paper with you, or if you're driving, you can think about the questions that I'm going to ask you. But it's an important, it's an experiential opportunity. And for us as adult learners, it's important to do that. So I'm gonna walk you through. I'll give you about 30 seconds to answer each question to yourself. So you can either write that down or you can think about it, and then I'll give you further direction at the end. So the first question is, what is your main source of information about the world around you? Think about what that is. You know, is it the local news? Do you go to Facebook? Do you go to the BBC online? Like, where do you get information about the world around you? Write that down if you have pen and paper with you, or think about that. The next question is, who is the most important person in your life? Who is the most important person in your life? Just write the name of that person down. And it might be more than one person, I recognize that. The third question is, what groups do you belong to? So it might be a church group, it might be a social club, you know, it could be your work group, you know, how you identify as a worker. So what groups do you belong to? What groups are part of your identity? Number 4 is, what is the one thing you've worked hardest for in your life? Can you identify the thing that you had to work the hardest for? It's probably, could be an education degree, maybe buying a house, you know, something like that. Number 5, what is your greatest source of joy? What brings you joy? Go ahead and write that down. Number 6, what has your culture taught you to value most? Cultural identity is important to us, right? So what is your culture taught you to value most? Number 7, if you have children, who is the most important person in their life besides you? So if you have children, who is the most important person in their life other than you? Number 8, how do you support yourself and your family if you have one financially? So what's your financial support like? How do you support yourself financially? Number 9, who are the family members or friends you are closest to? Name the people, the family members or friends you are closest to. Number 10, what is the place you call home? Is Lancaster your home? Is Montana your home? Where is the place that you call home, that you are rooted? Number 11, your gender identity. What does it mean? What does that mean to you? Whether you identify binary or non-binary, what does it mean to you to be a man, woman, or some other, someplace else on the gender spectrum? How does that influence your identity? Number 12, what makes you feel good about yourself? Number 12, what makes you feel good about yourself? And number 13, what role or roles give your life meaning or purpose? Mother, father, brother, sister, whatever role you have in your life, what are those roles that give you meaning or purpose? They're important to you. So pretty much what I've done here is I've asked you to create a picture of the most important elements of your life. Now I'm going to ask you to cross one thing off the list, or mentally off the list if you're not writing it down. When you cross it off your list, imagine that you are eliminating it from your life forever. So if you said the New York Times is your main source of information and you cross it off, it means that you will never read the New York Times again. You're not even looking at the headlines. So if you cross a person off your list, it means that you'll never see that person again. So go ahead and cross off one item. And now I'd like you to go ahead and cross off two items. So remember, when you cross something off your list, you will never have access to that thing or that person in your life. I could ask you to continue crossing things off your list, but I want to check in with you and see what you're thinking about this activity so far. If I asked you to cross off one more thing on your list, what would you do? Does anybody want to respond to that? I did give you the opportunity to unmute yourselves if you'd like.
So are you asking what our third thing would be?
I'm asking how you're feeling about me asking you to cross things off your list.
Oh, it's weird. Yeah, I made the list not really thinking too much. And now you tell me I never get to have these things again. It makes me kind of uncomfortable.
Yeah, okay. Somebody else want to weigh in? How are you feeling about crossing things off your list? Thank you, JL. It's so hard. If you made me cross off a third thing, I might cry imagining eliminating a person from my life. I have had people just like put their pen, like slam their pens on the table and say, no, I won't do this anymore. It is weird. It is difficult, right? I'm asking you to eliminate people from your life, to eliminate parts of your identity, to eliminate your history, your roots, to eliminate how you connect to the world outside of you. When we ask the question, why doesn't she just leave? These are the things that we're asking people to give up. We're asking the victim to make a decision about whether or not they have access to their children, or maybe the safety of their own life. Or they have to walk away from a family member, from their best friend who they've grown up with, because their abuser is isolating them and cutting them off from those people. They have to make that decision between somebody they've known for a lifetime and their safety. These are impossible decisions. And so when we ask that question, why doesn't she just leave? We need to be turning that language around. We need to be thinking through why, what are the barriers that prevent someone from finding self-sufficiency, that prevent them from finding safety. These are the elements of who we are and who we identify as, and the people who are important to us. So it's really important I encourage groups that before you think about asking that question again, think about how nuanced that might be. And I'm thinking that this is probably not brand new for all of you working with the populations who are vulnerable. But when you experience it in this way, sometimes it puts a different light on it. So thank you for taking the time, engaging in that, and whatever level you engaged in that activity. And if you have any more comments about it, I'd be happy to read them in the chat. Abusive behavior. So you may have, this is one of the goals that we had for today, and I'm not going to spend too much time on this because I want to make sure that we get to the impacts. Maybe you have seen this power and control wheel. And if not, you can Google that, and I'm happy to also share that document. I can send that to Allison along with the link to this recording and some other resources. But you can see that power and control just isn't about physical violence. That's the first place that most people go to. It can include sexual abuse. We often see abusers who use the children to control their partner and to keep them, to make them stay. And that's, you know, getting the children involved in the abuse somehow, making the children perform that somehow, using the children, you know, right down to threatening custody, that they're going to take custody of the children and that the victim will never see them again. That's a pretty common tactic that we see. Isolation, cutting them off, cutting the victim off from their support system, from their friends, from their families. Those were some of the questions of, you know, if you had to cut out the person in your life who is most important to you, or who are the friends or family members who are closest to you. Abusers cut off their support, the victim support system, so that way when it comes time for the victim to think that they might be able to leave, you know, the abuser will look around and say, where are you going to go? Who are you going to go to? They don't call anymore. They don't care about you. I'm the only person who cares about you. I'm the one who's still here. So there's lots of ways that they can use that isolation. Economic abuse is sometimes pretty subtle, but if they're keeping the victim from getting a job, from keeping a job, from furthering their education, furthering their professional career goals, controlling the finances, there's a full range of income ways, economic abuse, that we see abusers use. So there are many tactics that abusers use, and it's important to be able to know that exists, and to maybe just kind of look for that. Observe the behavior, observe the interactions that you might see between a victim or two adults who are coming into your practice, and just observe what their interactions might look like. That might tell you a little bit something about what's happening in their relationship. I did also mention earlier about the lethality assessment partnerships that we have with law enforcement agencies in Lancaster. This is really quick, but there is research that shows, research that tells us some of the indicators that victims experienced before they were killed. So there's a full body of research that Dr. Jacqueline Campbell conducted across the United States over, I want to say, 10 or more years. And essentially what she did is she went through homicide cases and reviewed who they connected to, where they reached out for services, who they might have disclosed to, who knew what was going on in the relationship, what were the things that were, what was the quality of the relationship leading up to that person's death. And they came up with 11 indicators that we can now use with law enforcement. Law enforcement can use this questionnaire and simply say, we know that victims who in similar situations have died as a result of the abuse that they experienced, and we're trying to help get ahead of that. Because what the research told us was that, I think it was more that it was about 34% of victims that had contact, no, it was 34% of abusers had contact with a law enforcement agency in the year prior to the victim's death, which means that the victim likely had some kind of contact as well, whether it was calling the police or maybe through probation or parole or something like that. We also know, and this is the statistic that always sticks out with me, 96% of the victims who were killed did not avail themselves of the free confidential resources like ours in their community. So every community across the country has a domestic violence program. And so what she found in her research was that 96% of victims had not been in contact with the local domestic violence program in the year prior to her death. And so what that means to me is that we need to do a better job of getting our services known in the community and building those relationships and partnerships where, you know, where people are going to be encountering other professionals in the community, and helping them to connect victims to our resources. What you see on the screen in front of you, strangulation, unemployment, stalking, separation, suicide threats, children who are not the abusers, these are all of the risk factors. There, like I said, there were 11 of them. These are the risk factors that came out of the research, and these are the questions that law enforcement are asking when they're using the lethality assessment tool. We also know that the presence of guns and the threat to use a gun or a weapon is especially dangerous for victims. We have also seen during this COVID time that the applications for gun ownership for permits and that the number of guns that are being purchased during this COVID time are higher. They are at the highest point that they have been since we have been tracking the purchase of weapons in the national database in 1999. So when somebody applies for a permit or applies to purchase a weapon, their application goes through a national database to make sure that they're not prohibited from owning a weapon. That database started in 1999 at the federal level, and we are seeing the highest rate of these applications since that database started. That's a little scary for people who are working in my field, because why are people buying guns? And we know that the tactics that abusers are using, that they're using COVID as one of those ways to control their partner. They're telling them misinformation. They're keeping them from access to proper information. They might be forcing them to go out without proper protections like a mask. So they are using COVID and the fear that's been, that's kind of grown up around COVID to control their victims. And we've heard that, we have heard that anecdotally from some of the folks who we've talked with. So leaving is not always safer. Going back to that question, why doesn't she just leave? We know that it's not always safer to leave. The research tells us that it takes about 7 times for somebody to leave a situation until they actually stay away from that situation. We also believe that every time someone leaves or reaches out for resources or assistance, that they're building their toolbox. So even though you might have somebody who says, I think I'm ready to leave, and maybe, you know, you've had that conversation with them before, keep supporting them, keep connecting them to resources, because when it's their time, they're gonna go. And it's our job to just be ready to support them when it's their time. It's also important to recognize that leaving, the time that is most dangerous for victims, is during that time when they're making these decisions and these plans to leave the relationship, because the abuser is now figuring out that they do not have the control that they thought that they did in that situation. And so it becomes a really dangerous time for victims when they are planning or escaping their situation. We can talk about the physical, emotional, social impacts of domestic violence on victims in lots of different ways. But because of time, I need to skip through that one a little bit, because I think that you probably see impacts. You see some of those impacts on the victims who you work with. I do want to bring attention some of this co-occurring disorder piece, because I think it's really important for the medical field, especially when you're looking at symptoms, right? You're working with a patient who's presenting symptoms. You're asking questions about what their symptoms are. You might be looking at their symptoms to make that diagnosis. And when you look at these three columns of diagnoses, we have anxiety on the left, ADHD on the right, and we have trauma in the middle. So there's a lot of similar symptoms or co-occurring symptoms there. It's really important for our medical practitioners to be trauma informed as well, because sometimes what looks like anxiety or ADHD might actually be a trauma history that's presenting itself. And with that, there's not really medication to be prescribed necessarily, but other support services like our services, or other, counseling or mental health services in the community. So I just wanted to throw that out there to think about trauma perhaps as a source of some of the symptoms you might hear from the patients you're working with, and to maybe explore that a little bit more with them about what their trauma history is, to help connect them to other support systems in the community. So risk is generated. We have it categorized in three ways. Risk is obviously generated by the abusive partner through the violence that they induce on the victim and on the family. We also know that risk for the victim is generated by who she or he is, their personality, their religious or faith beliefs, their connections in the community, their culture. Some of those questions that I asked you of the 13 questions earlier, right? Their identity, who they are. And there's also life risks. What are their finances? Are they living in poverty? That presents an extra barrier to self-sufficiency and accessing services, right? If there's physical, mental, emotional health challenges, that might be another barrier, another risk that is generated by their life circumstances that could get in the way of them accessing services or freeing themselves from an abusive situation. So you can see how these aspects, these different lenses that we look at risk, how they're interconnected, and can also be barriers to a victim who is trying to flee an abusive situation or get to safety. So what can you do? I have these safety assessment questions that I've also shared with some other allied partners in the community, who I've done a similar training with. Some very conversational things. How is everything at home? How are you getting along with your partner? Do you feel safe at home? Is anyone hurting you or controlling you in your home? I don't know if you're using any kind of formal assessment, but even sometimes just having some informal conversation. I hope that that you're not afraid to ask those questions because of what answer you might get now that you have our contact information and a little bit more. If you ask the question and somebody says, no, I don't feel safe at home, you don't have to feel pressured to figure out where they're going to go. You can let them know that our services exist, that they're confidential, that they're free. You can offer to connect them right there in the office. You could sit and support them in the, during the conversation, or, connect them through the phone call. But I don't want anybody to feel like, oh no, if I ask the question, what happens if they say that they're not safe or they don't know what to do? You don't have to be the expert in that situation. That's what we're here to help you with. And so hopefully that will give you some more confidence to be able to engage these conversations. Some other quick things that if you have someone who's disclosed to you that they're preparing to exit an abusive relationship, or that they're trying to figure out what they want to do, these are some things that we often suggest when people are in that planning process. Where are the safe places that they can go? And the safe places that maybe the abuser doesn't know about. Is there a friend or a family member who they don't know about, who lives nearby, or who they might be able to get to? Obviously, safe shelter is always an option as well. The National Domestic Violence Hotline, that's a number that they can call, that number, and they can get information about any program across the country. They just give them a zip code or a city and state, and they'll connect them to those local resources. Obviously, our information is a local resource for them, but if somebody's talking to you about preparing to leave, these are also some of the really concrete things that's helpful for them to have before they leave. photo ID, birth certificates, social security cards, immigration paperwork, house keys and cars, bank information. Those are all of the practical things, because it's much harder sometimes to get that when you've already left the situation. It presents some additional steps that need to be taken to get those things. So we often suggest that if somebody has the opportunity to plan, to think about squirreling away these documents either in a safe place or giving them to someone to hold on for them. But having these copies really opens the doors to other social service agencies in the community, because these are some of the things that you need to get processes started. So with that, I have some resources that are also available here to you: the National Domestic Violence Hotline, PCADV. Locally, we have ACEs Connect Lancaster through the Trauma Informed Lancaster that's housed at LGH Penn Medicine. I'm going to leave this other screen up for you to take a look at in case you're writing anything down. But I do want to open it up for questions. If anybody has a question, please feel free to unmute yourself or to type something in the chat. I know this was a lot for just an hour, and I'm happy to do a follow-up session. Allison, we can talk more about that if you're working, if staff figure out that they want more information. We can certainly go deeper into any aspect of this that you would like.
Angela, thank you so much for joining us today. It was helpful for folks. The session has been recorded, and I'll send that out as soon as we have it. And if there's content that we would like to invite Angela back to talk to us a little bit further about, please let me know, and we'll be sure to coordinate.
Absolutely.
Thanks, Angela.
Thank you for being here. And please, I forgot to put my contact information there, but if you have any specific questions, you can get my information from Allison. You can also find me through the hotline. They'll send you to my voicemail. But we really do see this as a partnership and relationship building. And so I really hope that if there's any additional information that you need, that you'll reach out either directly or through Allison, so we can continue to do this work together, to keep our community safe and to make sure that the resources that our shared clients need are available to them. Have a great afternoon, everyone.
Thank you.